Good evening, ladies and gentlemen. Welcome to University of Otago and welcome to the fifth of 6 public lectures that we're doing this year. For people who don't know me, my name's Peter Joyce. I'm Dean of the Medical School here. It's my pleasure tonight to introduce Associate Professor Suetonia Palmer. She did her medical degree through University of Otago, but did all her specialty training as a nephrologist or kidney specialist in Christchurch. And while she was in Christchurch during that training, she completed a PhD with Professor Andre, who was head of our Department of Medicine at that stage. She then spent 2 years at Harvard University in the United States and came back onto our staff in 2011. And it's a great pleasure to introduce her to talk about how can we learn where the medicines work and are safe. Suetonia.
Thank you very much, Peter, and thank you everyone for coming out to listen to the talk. And I'm very, very glad that I'm not competing with a very exciting cricket match this evening. I'm going to talk about how we know whether medicines work and how do we know that they're safe for us. And in some ways it seems like a bit of an odd question. Surely we know that medicines work. How can we not? We use them all the time. Many of them use them every day. What is it about them that we don't know enough about? So what I'm really going to talk about is, are we testing the medicines that we use in a way that we can then learn about whether they can improve our well-being? Are we actually testing medicines to prove that they work in ways that improve our health? And I'm going to suggest this evening that sometimes we don't. In fact, a lot of times we actually don't test medicines in the way that we need to be. A group in the United Kingdom actually looked at the totality of the information we have about medicines and suggested quite provocatively that approximately 85% of the research we do about medicines is a waste. It doesn't actually tell us about what we need to know about healthcare. It's a highly provocative statement, but I'm going to suggest to you in many ways through the lecture this evening about how that might actually be true. Because drug development and medicine testing in the world is a $1 billion industry. In fact, in 2010, $250 billion was spent around the globe on testing medicines. So it's really important that we get it right, and it's really important that we spend the money in the right places, because as we know, money doesn't grow on trees. To put this in another way, in the 2 decades between 1970 and 1990, for a single drug that we were testing whether it worked or not, we gave 20,000 patients in randomized trials placebo treatment when we actually had enough information about that drug to say that it would actually have saved their lives. So we were continuing to do trials through the 70s and 80s for a specific drug when actually we had enough information in those trials to actually show whether that medicine worked or not. And so this problem is actually continuing, and I'm going to show you how. I'm going to suggest that we get information about medicines absolutely all the time. We often don't realise that we get a lot of health information in our daily lives, on the internet, on the TV, telling us what we should and shouldn't be doing in terms of our health behaviour and which medicines we should be taking. And here's just a very simple, obvious example. This is from the National Health Service, so this is our equivalent of the Public Health Service in England. This is their website about choices we should be making. And they here are talking about water. And actually they give us very specific advice about water and how it will improve our well-being. Women should drink 8 glasses a day. We've all heard that before. Men should be taking 10 glasses of water or fluid a day. That is very specific health information that we receive. And what we need to know or need to understand is, where does that come from and is it true? Here's another example. It doesn't take you very long to find these on the internet. One about probiotics. And this evening's talk's not about probiotics, it's about the health information that we receive. And in this example, it's saying that probiotics target and help against infection of our gut and improve our well-being. So we're surrounded by health information on a daily basis. How do we sort through it, and how does the health system sort through the massive amount of information that we get about medicines and health interventions? What we do is we try and find for each particular disease, and the details of this slide don't matter, we try and find for each particular disease a set of interventions or a set of medicines or a set of drugs that we then develop and trial and test, and our ultimate goal is to improve or reduce that disease process. And what I'm going to argue this evening is that we're not quite getting to that end point of improving our well-being through our drug development. So let's start with a really simple question about how we even test medicines in our population. We go right back to the observational study. So we have all the way through our history observed the world around us, observed what natural phenomena are around us, and that has helped us uncover important health problems and actually solve them. So there's this lovely story, and I'm sure that many of you have heard this story already, of John Snow in London in the 1800s. And what they realised was that there was a huge outbreak in central London of people dying of a diarrheal illness, which was cholera. What John Snow actually did was one of the most elegant observational studies that has been done, because no one knew what was causing the diarrhea. They didn't realise that it was a particular bug, so no one knew what was causing the diarrhea. And what John Snow did was what was called shoe leather epidemiology, or shoe leather observation, where he literally walked the streets, and on the map he recorded each house where someone had died from cholera. And each house that had some death in it was made black on his map. And what he showed was that the black dots were all congregated in a certain area. And he drew a kind of a natural observation or a natural circle around that. There were plenty of theories abounding at the time about the cause. Was it the air? Was it pollution in the air? Was it elevation above the river? No one really quite knew why this was happening. And what he then showed, which was very elegant, was he then plotted the water pumps in London at the same time. And what you can see is right in the centre of that circle is the water pump for Broad Street. And what he then did was went to the community and talked to them about this and showed them this, and the community were very surprised about that result, and they demanded that the handle be removed from the pump. And the handle for that water pump was removed, and the cholera epidemic started to recede. So that was a very elegant observational study, a natural observation of what was happening around us. And what he showed was that everyone who died had drunk contaminated water, and no one who survived had everyone who survived had drunk clean water. So there was this natural division in the population, a natural observation showing that it was the contaminated water that was the cause of the problem. And we've done this for smoking as well, elegantly in the 1940s. We've shown very clearly that people who've smoked have then come into some trouble with early death and smoking-related diseases. So the observational study is a very powerful way of understanding public health and what's causing disease. But using observation to test medicine is a problem, and I'm going to show you why. So we can also use the observational study to test medicines. And I'm going to show you a very famous example where a group of researchers divided women, thousands of nurses, into those who were taking hormone replacement therapy and those who were not. And they then followed those women over a period of time to discover what happened to them. And the hypothesis was that older women who were not producing as much estrogen or progesterone as they were, if we replaced that, then that may be a good idea. And so the investigators did an observational study where they looked at what happened to people, women who had chosen to take HRT and those who had not. And what they showed with this observation was that women who'd chosen to take HRT actually were much less likely to die, substantially less likely to die, or much more likely to survive. This was a very powerful piece of information at the time in the late 90s, and I'm sure many women remember the discourse around this, the fact that we were actually then went out and promoted hormone replacement therapy on a large scale. It must be good for us. But observational studies actually don't help us understand whether medicines work. The problem with the observational study looking at medicines is that the chance that a woman is taking a medicine is not random. It's related to a whole bunch of other things. So the women in this study who were taking hormone replacement therapy were different from women who were not in very important ways. That wasn't a random thing. And so what I'm making up a few things here, but you could imagine that women who were taking hormone replacement therapy in this study were health freaks, or they were vegetarian, or they were more health conscious. You could imagine that they took maybe different care of themselves, maybe, or they were much more likely to have different health behaviours than women who were not taking the medicine. So women who were not taking medicine or hormone replacement therapy may have had different educational opportunities, or may have had different priorities in terms of going to their GP or not. And it's probable that the difference between the two women and their likelihood of surviving or not was actually related to these other things that the investigators couldn't measure, because these things were actually quite difficult to measure. So here is where we talk about the randomized trial. And the randomized trial overcomes many of the problems that the observational study has, because the randomized trial, which was first really, I think there's a randomized trial report in the Bible, I hear, but one of the first ones was in the 1940s, where people treated people with very advanced tuberculosis with an antibiotic called streptomycin. And the reason they did that was because streptomycin was quite difficult to produce. It wasn't produced in the mass way that medicines are now. There wasn't very much of it. There needed to be an allocation of treatment, and the way to treat people with tuberculosis was to randomly allocate them to streptomycin or not, to discover whether it was effective. So that was one of the first randomized trials. So what happens in a randomized trial is that people are randomly allocated to different medicines or different healthcare interventions. And their chances of receiving a health intervention is purely by chance. And therefore, those who receive the medicine are very likely to be very similar to those who, say, receive the sugar pill. And the only difference between them is the fact that they've received the medication. So they're likely to have the same educational opportunities. They're likely to have the same ability to see a GP, etc., etc. And this randomized trial has been a profound and amazing kind of technology, if you like, in the testing of medicines. You're sensing maybe there's a big but coming along. But here is the result following the nurses' study of the hormone replacement therapy. Then the Women's Health Initiative came along and randomised women to either hormone replacement therapy or not, so that the women were similar in every other respect other than receiving the medication. And the reverse was found. So instead of women who received hormone replacement therapy survived longer, they actually received harm from the treatment. This was a huge surprise at the time. The expectation was that the benefits of hormone replacement therapy would be confirmed, but they weren't, in very hazardous ways. So women who took hormone replacement therapy in the trial had much higher rates of breast cancer, experiencing cardiovascular disease and clots in their lungs. And so this shows us that if we're testing medicines, we need to be very careful about how we design our studies and how we actually test the treatments that we need. So the randomised trial has been a fantastic boon for health research over the decades, but we're running into problems, and we're still suffering from a huge amount of waste when we're measuring the effects of medicines for a number of issues. And there are major problems with randomised trials that are preventing us from getting the information that we need out of them. What I'm going to do now is talk about some of those problems. I'm going to then talk about a new technology that tries to overcome those problems, and then I'm going to talk about some solutions. Where to from here? We've got this problem, how are we going to solve things? So one of the problems with randomised trials is we all know that we live in an absolute information explosion. We just simply need to look at our email inbox, or the amount of information coming at us in our daily lives is just extraordinary. And the same is for medical research. So this is a simple graph where if you were to Google randomised trial and heart attack, and you look at the number of trials that are available at each of these dates, you can see that the curve is exponential. So when I was a medical student in 1995, and I was trying to write an essay, I would only have to deal with about 6,000 papers, and they would have all been stuck in the library in physical journals. Now, if I'm trying to write the same essay, I would have to deal with 25,000 pieces of information, and those pieces of information are now electronic, so they're everywhere. And you can see that in the last decades, the amount of information has increased tenfold. And what this means in practical terms is that health practitioners, now this was written 20 years ago, health practitioners need to read 19 original articles a day for 365 days a year to keep up to date with their field. Well, that's what it feels like. And this is increasing exponentially. So there's information that shows that if a doctor does a clinic during the morning, for every patient he or she sees, there are 2 or 3 important treatment uncertainties for every single patient they see. So we live in a life of uncertainty, and we live in a life of exploding information. And in the next 10 years, the amount of days it will take for the amount of information on the internet to double is only 73 days in the next 10 years. So you can see that this problem is only going to get worse. And so we need to develop ways of curating the information that's coming at us in ways that we can use. The reports of trials are actually really hard to discover. You could imagine that research trials that are really powerful, really important, really exciting, really snazzy are right out there in front of us. We don't actually need to try very hard to find them. They're often on the internet or in the paper or on the radio, or there's a TV report. So the really big, exciting, positive trials telling us that things work are right there in front of us. But the little trials that say the medicine probably may not work, or the little trial where the results weren't that clear, or the little trial where the researcher then went on to something much more exciting, tends to get stuck in a drawer. And what we know is about half of randomized trials that are ever done get stuck in the drawer and don't actually come out into the light of day, or are in tiny little kind of conference proceedings, little pamphlets or little books. They're notoriously difficult to find. And so you can imagine there's bias in the amount of information. We see the really whiz-bang types of trials, but we don't see the ones that say the treatments don't work so well. And so therefore we get a skewed view of whether medicines work. This is a very good example. Not all trials are made public. So when a industry player is making a new medicine, they need to ask a drug agency for approval for that drug to be able to be prescribed out in the community. And they apply to things like the Food and Drug Administration in the United States, or the European Medicines Agency in Europe. Those reports given by drug companies to those agencies don't need to be made public. And you can imagine that some of those reports don't necessarily see the light of day because they're not that interesting. There's stacks of them. They may not actually really say very much. They don't see the light of day. The really big trials do see the light of day. And what some very clever researchers back in 2008 showed was actually if you take only the published trials, you show quite big effects of antidepressant therapy. But when you actually go away and find all those other trials that were never made public and put them into the mix, the effects of antidepressants is not quite as big as hoped. So it depends very much where we're getting our information from, when we're deciding whether medicines work or not. This is one of my favourites. Trials say lots and lots of different things. It doesn't matter what treatment X is, it actually happens to be a type of dialysis. But these two reports, one on top of the other, are from the same major American journal for kidney research, 1 month apart. And the top one says that treatment X given to patients improves survival. And the bottom one, a month later for the same treatment, says treatment X did not affect survival. What on earth are we supposed to think about a medicine or a healthcare intervention and whether it works or not when we've got a huge amount of information out there that's actually clashing with each other and actually saying different things? How do we deal with that? How do clinicians, how do people writing policy, how does Pharmac deal with whether we should be using treatment X in New Zealand if the actual research is actually saying different things? And one of the key problems is that trials are often too small to discover the answer. We are blessed with a huge number of very, very small trials where they're just too small for us to actually know what they mean. The patients in one group may do better than the other, but because they're so small, we can't really tell whether that's an important difference, whether it's a significant difference, or whether it's just by chance. And in my field in kidney disease, the number of small trials is absolutely extraordinary, and each individual trial can't really tell us very much. So we are suffering from a huge variety of trials, a huge amount of information, and that information, if we're not careful, just looks like gobbledygook, and our ability to understand it and use it in ways that improve our well-being is that we're actually falling further and further behind because of the amount of stuff, the amount of research actually being done. Traditionally, we have used reviews where people sift through the information that we have, pick out the really, really important bits and put them into single pieces of work. And these are incredibly popular, as you can imagine, because they allow us to understand the body of evidence in front of us without us actually having to go and find and read all the papers. And one of the most important ways of doing this is to ask an expert to sift through the information in their field of expertise and tell a story. We call it a narrative review. It tells a story of the evidence as it stands. Unfortunately, these narrative reviews are highly cited. They're very popular. People like reading them. I like reading them because they allow me to understand a body of information very, very quickly. But unfortunately, because they're not done systematically, for no particular fault of the author or anything, they can give a picture that's not complete, shall we say. So they draw on information that the writer already knows about, but doesn't necessarily draw on information that's hard to find. And so we run into a problem where the narrative review can't tell us the whole story. So my reason for getting out of bed in the morning, strangely enough, is the systematic review. And the systematic review I'm going to spend a little bit of time on now to tell you a little bit more about what that is. So all the dots on the screen, just imagine that they're a single piece of information about a particular disease or about a particular medicine. At the moment, they just look scattered, disorganised. We can't really understand what they mean. Systematic review means that I physically go out and hunt down all the trials for a specific research question. So, for example, does blood pressure lowering when I have diabetes help me survive for longer? A good research question. And a systematic review goes and hunts for every single piece of evidence about that particular research question and corrals it into some sort of order using digital technology, using ways of understanding that information to create a complete picture of the evidence on that topic. So I'm going to give you a couple of examples. The first ever systematic review was done by James Lind, MD, and the topic was scurvy. And the British Navy was being scoured by scurvy, and no one really knew what they could do about it. And James Lind set about a critical and chronological view of what has been published on the subject. So clearly this information overload has vexed us for centuries. And what he did in the pre-internet era was literally go and find every report that he could find. I really don't know how they were indexed. I don't know how he found them. And looked at every single treatment that had been used for scurvy up until that date. And there were all sorts of things: nutmeg, beef stock, vinegar, and of course oranges and lemons. And he brought all that information together in a single place and looked at the evidence and discovered that the sailors who were receiving oranges and lemons recovered from scurvy. And those that received beef stock or vinegar or oil this or nutmeg that, it didn't really make a difference. And this was the first ever systematic examination of the evidence. I love this little quote because this is what my day job feels like. Before the subject could be set in clear and proper light, it was necessary to remove a great deal of rubbish. So he had to literally sift through a lot of stuff to actually get what he needed to find. And this discovery, within 20 years, eradicated scurvy from the British Navy. And if he hadn't have done this, you know, who knows what lands the British Navy would have lost because they were all too busy under the decks with poor old scurvy. So the systematic review, even then, was a very powerful technology for understanding whether something works. And he found that it was oranges and lemons. I'm going to come back to this example that I gave right at the beginning to show you how this happened. So this is the example where we had a treatment, but we kept on doing trials even though we had the answer. How on earth did that happen? And here's how it happened. This is what's called a forest plot. Kind of looks like lots of horizontal trees, really. But it shows you every dot is a single randomized trial. And every whisker coming out the sides is how confident we are about the result of that randomized trial. And every dot on the left-hand side of the vertical line tells us that the treatment was effective. And every dot on this side of that vertical line tells us that the treatment wasn't effective. And you can probably hazard a guess that most of the dots are in the right direction. Most of the dots are on the left-hand side of the line. But because the trials are all small and the whiskers coming out of the dots cross that vertical line, that means that we can't be sure whether that treatment is effective or not. Those trials, every single one of them, included patients, and in total, those trials included 40,000 people. What an incredible effort, what an incredible amount of energy and resource into these trials. And here's where systematic review comes in. Because if you add one trial and then you add the result of the next trial to the first one and combine them and look at that result, and then when you do a third trial, you add that to the two before it to find the result. And then when the next one comes in and so on, what do you find? And this is what you find. It actually only took 3 trials for it to be absolutely clear that streptokinase, which was the clot-busting drug of the day, actually improved survival, actually saved lives. And what happened was another 40,000 people were included in randomized trials because this organisation of the information, this curation of the information had never been done. Now you might think, oh, that's in the 1990s, but I'm afraid this still happens. And so much of my work has been about actually putting all the trials in kidney disease together and showing that sometimes we don't actually know whether treatments work, even though we've done a lot of trials. Or even worse, we've kept on doing trials when we probably should have stopped, because if we'd curated it like this, we would have discovered 20 years ago that a treatment was safe or harmful. So systematic review is an unbelievably powerful tool, and it's very simple, although it takes lots of man hours to do to actually discover whether treatments work or not. Even with the systematic review, we still suffer disconnection between research trials looking at medicines and actually improving our well-being. And I'm just going to introduce one more concept that I think is important to this story. We are increasingly, as a research community or as a community, we're increasingly measuring markers of disease rather than the disease themselves. And as someone who's read hundreds and thousands of trials, what I've read is that in the 70s and 80s, we tended to look at whether treatments actually had an effect on the way a person felt. But the trend has become that we've started to actually measure markers of disease in place of measuring the way people feel. So here's what I mean. We have a disease, and that disease has a variable impact on the way someone feels, or the way they function, or the way they survive. And in between that, we've got a marker of that disease. So say we've got osteoporosis, we can measure how dense the bone is. Or we have hypertension, we can measure the blood pressure. So the marker is the blood pressure. Hypertension would lead to poor survival, but the blood pressure is the marker of the disease. Cancer, there's a lot of biomarkers that we use to detect whether cancer actually is present and responses to treatment. And what we've done is it's a great idea, is that we then introduce medicines that then try and change that marker. So we put medicines into trials to try and see if they change the marker. And what we've forgotten is actually to test whether changing that marker actually translates into something that we feel or function. So for example, osteoporosis. We've got the bone mineral density scan, which tells us the density of someone's bones. We have a potential treatment, which is vitamin D. Ultimately, the treatment is trying to prevent fracture. But many of the trials measure bone mineral density as a way of measuring whether treatments work. So we've kind of forgotten about the fracture bit, and we've started to focus on the bone density scan bit. And when I've looked at trials in people who've had a kidney transplant, I've discovered that most of the trials stop at the bone density and never measure fracture. And that's happened time and time again. One more example is diabetes and kidney disease. We try and lower blood pressure because we know that that probably helps improve survival. But our trials have stopped measuring survival consistently and generally focused on the effect of treatment on blood pressure. And my latest work has shown that despite nearly 200 trials involving 45,000 people, there's actually no evidence that blood pressure treatments improve survival with people with diabetes and kidney disease. This is right here and now. So we're still getting stuck on measuring these intermediary markers, which tell us a lot, but we actually haven't included in our trials the effect of treatment on the way people feel and survive. And this is a big problem because this is an enormous amount of effort. This is billions of dollars of work, and we're still not really finding the answers that we need. So how can we respond? I'm going to get a little bit more upbeat here. What I'm going to argue is that we actually need to get even more digitally savvy than James Lind all those years ago. We need to get even more clever at combining the information we have in technological ways. And there's just an amazing amount of work happening around the world actually doing that. I'm going to show you a simple example. So imagine these dots are individual trials. At the moment, all we can do, or all we have been able to do in systematic review is say, these trials mean that one treatment is better than another. And what we now are doing is using, instead of standard ways of combining, we're actually using network analysis. So we're plugging all these trials into a network of electronic information. And as each trial comes along, we're plugging it into this electronic network. We're then building very complicated statistical models that I don't even begin to understand to allow us to drill down into that network and discover whether any of the treatments available for a particular disease are effective. And this is called network meta-analysis, and it's coming to a journal near you soon because it's incredibly powerful. This is a very good modern example. A group in Greece looked at all the antipsychotic treatments available for schizophrenia. So you can imagine a clinician and a patient having a discussion about that many treatments. And what these researchers managed to do was to plug those treatments into a single network and look at what they did compared with each other. They were literally able to make connections between all those drugs. And what they were then able to do with that information, which is just profound, is they were able to rank them from the best, very best treatment, and this was measuring symptoms, to the very worst. So they were able to tell their patients, this is clearly the best of all these treatments. And actually this hasn't been possible until the last 5 years, and this is highly novel and highly exciting. And you can imagine that there are so many diseases out there where there are, tens of treatments. And this is an opportunity for us to be able to understand all the treatments that are available without even having to do a single new randomized trial, because this is done with all the information that's already there. We need to explore our patient experiences in much greater detail, move away from the markers, which are incredibly important, but actually understand what our patients are experiencing, because that allows us to create healthcare that actually is addressing those issues. So I did a review of, in people who have kidney disease, we suggest quite close dietary management. And this little quote from a study that I did, the patient was saying, I always tell the dietitians that the dietary restrictions would actually make people starve. There are so many foods that I should eat just a little. If I did as instructed by the dietitians, I would die from starving. So this is a patient saying, you're telling me about a treatment for my kidney disease and it's making me feel like this. And we need to know this so that when we plan research and plan new treatments for conditions, that we understand what the treatments we're already using, how they're having an impact on people. We actually now need to, and this is a global movement, involve patients and clinicians in priority setting for research. So traditionally, patients have been the participants. Well, actually what's happening now is patients and their carers or their families and clinicians are joining together in collaboration to actually decide which research questions are the most important. Up until now, it's been people in universities or in industry deciding which are the most important medicine questions we need to answer. But you'll be pleased to know that the tide is turning. And James Lind, who is the author of that wonderful systematic review, has had the James Lind Alliance named for him. And the James Lind Alliance is a group that has the kind of infrastructure to bring patients and families and clinicians together to collaborate on what are the most important research uncertainties in their field. And so this is an example from the top 10 research uncertainties brought about by the James Lind Alliance for local prostate cancer. And so the top research uncertainty brought about by patients and clinicians is how can over-treatment of cancer be prevented? Which I think is really interesting that they find that that's the top treatment uncertainty. And at the bottom, are there any dietary measures that can prevent prostate cancer or slow its progression? So these are research questions that are coming out from the people who are treating and experiencing the disease. And we've done something very similar, well, we're working through something very similar in Sydney with kidney disease. We've talked to a huge group of clinicians and patients about research priorities in kidney disease. The top research uncertainty for that group is how effective are lifestyle programs for preventing the deterioration of kidney function in patients who have early kidney disease. That's the top research uncertainty. That's how many randomized trials we have to answer that question. So we've got a huge mismatch between what research we're doing and actually what patients and clinicians consider their most important priorities. We then need to move on from that and actually require trials to measure the outcomes that matter to the people who are deciding those priorities. So instead of measuring markers, which are incredibly important, we also need to measure things. So this is an example of live births per every in vitro fertilisation. So instead of measuring a hormonal marker, we're measuring something that we think is important, such as live births. And here's some really clear examples of potential endpoints in trials that we're not measuring properly at the moment. So getting back to work, returning to full physical activity, delays in anxiety in treatment, the risks of infection, loss of mobility. These are all incredibly important things we're not measuring currently in clinical trials. And then finally, we actually need to make research much more normal. It's not something special done in that building over there. It's done in the hospital every single day. So we need to embed clinical research in our daily clinical practice so that when I come to hospital and there's a research program going on, as a patient, I can then have the opportunity of seamlessly joining a research trial. That needs a huge amount of information technology support. It needs normalisation of research within the healthcare culture. But I think it's really important. So we need to measure and evaluate our clinical practice much more routinely. We need to use patient-centred performance indicators, because at the moment in my field we use all sorts of strange markers to measure performance when we don't actually measure the things that our patients tell us are important to them. And we need to embed these randomised trials into just daily healthcare and use information technology to do really large trials across large numbers of sites to be able to do the large trials that tell us whether treatments work. So that the research, learning whether medicines works, actually includes health systems, it includes big data so that we can understand that information. It includes funders, of course, because we need money, but it also includes people who are experiencing the disease and the communities. So this is almost my last slide. What I might imagine if I was to enter a healthcare practice in the future would be that healthcare practice would be familiar and understand systematic review, or at least understand its importance and what it means to learn about treatments and whether they work or not. I would hope that they would then offer me effective treatment or priority treatments within large randomised trials. So either they would know that a treatment was effective, or there would be an important treatment uncertainty and I would be able to be involved in a large randomised trial. The health centre would know which outcomes of treatment I would value most highly, or someone like me would value most highly. And that healthcare system actually measures those outcomes. So it doesn't measure something odd or some strange biomarker, but measures those outcomes. That health system is then linked to a strong peer network and good information technology so that those outcomes can be measured. And then there is a review to see whether those priority outcomes are even achieved within trials or within standard healthcare practice. That health system would then adjust practice, learning from those measurements, and then the full cycle. So that health research becomes normal, it's done on a very large scale, it's facilitated by good information technology, and it's constantly reiterative so that we're constantly aware of whether treatments are working for us or not. And that's all I have to say.
Thank you very much. We have 12 minutes for comments, questions, but I think
A couple of comments. The first one relates to the question of these this meta-analysis that we're talking about. But we also need to go, I think it's great that we're moving into that area, but it's still dependent, it's still sort of observational. It's dependent on the model that we use for meta-analysis. Don't we need to go a step further back and actually make sure that our trials are designed together to go together rather than pull together afterwards?
That's an absolutely wonderful point, and that's actually what's starting to happen. we need to make sure that trials are all measuring the things that matter to us, and therefore they're much more easily combinable. What you're saying is, even from the get-go, before a trial is designed, we're thinking how it's going to plug into our network of information. And that's absolutely essential. So the collaborative meta-analysis, where you're designing the study with the rest of the information in mind. That's not necessarily meaning you're doing the same study over and over and over. It just means that studies are similar enough that you can combine them and increase the power of your observations. Yep, so excellent point. Yeah.
The point you made about systematic reviews and bringing everything together, I was just wondering, though, with regards to that, often there's a tendency with studies that are like positive get published and the negative studies not get published.
Yes.
Can that be still be overcome by the system that you propose?
Yeah. Yeah.
Is that still happening today?
Yeah. That's a great question. The group I work with is the Cochrane Renal Group in Sydney, and it's filled with extraordinary women who, in the last hour of their day, physically hunt through conference proceedings and journals to find trials that might otherwise not be indexed properly. So we go hunting, but we still don't overcome the filing drawer problem where trials are just tucked away or data is tucked away. We have statistical methods to show that trials are missing, and we can overcome that using statistical methods, but we still have a tendency for trials to overemphasize positivity. And the reverse of the coin is equally important, is that trials tend to measure whether drugs work. But actually, if you notice in my introduction, we actually often don't measure whether they're safe, because people running trials actually aren't as interested in adverse effects as they are on whether a drug works. And that's a very difficult problem to overcome, and trials don't actually overcome that. We then need to kind of reverse and backtrack and go to very, very large observational data sets to look at adverse events, and that's how many of the drug adverse events were actually discovered when we actually went back to the observational data set.
I know another way that they've tried to overcome the trial problem is actually having to register your trial before it begins, so and then you can put the results.
Absolutely, yes.
Whether that's actually happening.
That's a great point. It doesn't, so these days, if you're going to do a trial and you're going to get it published, you have to report before you submit it for publication to a large registry to say who you've included in the trial, what treatment you've used, some very, very basic details. And you're given a unique identifying number. And that came in 2006. As a meta-analyst, I've discovered that that doesn't happen as often as we would like. So even though it's designed to be a universal thing, that every trial published needs to do it, only about 50% of trials are being registered at the moment. But I would have to say that there's been a sharp uptick in the last year or two, which has been really helpful. But if a person doesn't ever try and publish their trial, then that trial won't appear anywhere. It's kind of invisible. And trial registration only partly overcomes that, yeah.
I was wondering about the meta-analysis. What actually is it that determines whether or not two trials have aligned or
So those lines, that's very observant, those lines were trials where treatment were directly compared within a trial. So if treatment A and treatment B were compared within a single trial, there would be a line drawn between treatment A and treatment B. If treatment A and treatment C were compared in a trial, then A and C would get a line. But maybe there was no B versus C trial, so that wouldn't get a line, but using statistics you can actually understand whether B or C are better than each other, even though the trial has never been done. And so that's the power of network analysis, and that's what allows you to rank the drugs from, you know, really great to very poor. Mm.
How much influence did the drug company have on the hormone replacement drug research?
That's a really good question. We absolutely require the drug industry for conducting most of that. There's a huge amount of money that goes into drug development, and it's absolutely essential that that drug development is funded by the industry because it's, you know, billions of dollars. What we know is that drug company funded trials tend to be more positive than non-drug company trials by a small margin. It's not a huge margin. What we also know is that drug company trials tend to be better quality than non-drug company trials as a rule. So they're actually very high quality trials. What we also know is that drug companies tend to compare their drugs favourably with medicines or drug alternatives or treatment alternatives that might show their drug to be in a better light. So there's a whole bunch of issues with drug company trials that separate them from, say, what we call investigator-led trials. What we do in meta-analysis is we actually look at the quality of the information coming back to us from each trial using a standard set of criteria. And we use that to actually tell the reader about the confidence that we have in the results of our analysis. So we can say there were 80 trials, but many of them had methods that make us less confident in their results. So therefore, even though this drug appears to work, we're not that confident about this result. So that's how you can adjust for differences between trials and differences between methods within trials. Yeah.
Some research has shown that people react differently to certain drugs. So how do you factor that into your analysis when you're looking at comparing different research groups?
Yeah.
Some people will react to the drug in some way.
That's right. It's a really good question. So what meta-analysis allows us, if we've got enough information, it allows us to tell us when the drug works for whom. And so we're able actually to understand whether the drug has different effects in different people, which is incredibly powerful because in single trials we often don't know that. So to give you an example, one of my recent pieces of work, we use statins, which are lipid-lowering medications to protect people against cardiovascular disease. There are 88 trials, and some of them are in people who have mild forms of kidney disease, and some of them are in people who have very severe forms of kidney disease. And the convention was that the statins were equally good for everyone. And actually what meta-analysis did was it gave us enough power in the analyses to actually show that people had different responses to treatment based on the severity of kidney disease. So that people who had mild forms of kidney disease got a huge amount of benefit out of statins, whereas those who had severe kidney disease and were treated with dialysis got only a very, very small benefit. And that was a completely new piece of information because we were able to look at different populations within a huge amount of information. We were able to say that. And that's actually been incredibly helpful. And that's actually gone into global guidelines in terms of who might benefit from statin therapy and who doesn't. So meta-analysis actually gives us even more power to understand when treatments work for particular people. It's not a perfect science by any stretch, but it can be very helpful. Yeah.
I can see from a scientific point of view, the temptation to have a measurable result such as blood pressure lowering or diabetes results, bone density scan. Has work been done around how you measure the patient's feeling of well-being? Because there's a lot of suggestion, a lot of suggestion around if I'm taking something, I'm going to feel better.
Absolutely.
And how do you actually quantify that to make it benefit
Yeah.
for now?
Yeah, that's a great question. So we have, quality of life scales which measure how someone feels along a kind of a visual and, some sort of scale. And I would suggest that that's that's a difficult thing to use and almost runs the risk of causing the same problems as the markers themselves. So that's where this effort to actually ask people what kinds of outcomes they value, because a health quality of life score of 3.8 doesn't mean much to me, and it probably doesn't mean much to the average person in a trial, whereas much more hard and fast outcomes like time taken to return to work, ability to return to full function, or maintenance of full employment, or those sorts of things. We're very early in the science of understanding actually what matters to people in diseases and actually what we should be modifying. So, and that's where my group in Sydney are working on with people with chronic kidney disease to actually find out, if you have this particular disease process, what is it that's important to you that you want to maintain through treatment? Is it to maintain days out of hospital? Is it to maintain time with your family? Is it to keep a full-time job? I think we need to be much more concrete about our outcomes, and I think I don't begin to know what those outcomes are, but someone who's experiencing the condition does. And we need to work very hard to find out what those outcomes actually are. So then we can then demand, much like the trial registration, we can demand that trials actually measure those outcomes, otherwise they won't get published, because that's the only way you can make trials actually trialists behave.
I can see that measurable for acute and current disease, but a lot of treatments are for long-term prevention, and people are not experiencing particularly distressing symptoms at the time.
Yeah,
So,
yeah.
how does that fit into the model?
Well, exactly. We live in a globe of chronic disease and multiple disease as well, so that people don't only just have one condition. And I think, as I say, we're at early days. I don't even begin to conceptualize how we deal with preventive treatment. Other than creating the same sort of structures about asking people who have, say, hypertension or high blood pressure or high cholesterol, what is it about treatment that they hope? And basically we just have to do the big trials that prove those outcomes. So if it's ultimately survival, then we need to do those big trials. And that's where facilitating trials within standard healthcare allows us to do those big trials much more easily.
I'm aware we just passed 8 o'clock and we try and finish on time, so I would ask you all to thank Associate Professor Palmer for her speech. I'm sure she's happy if you've got a burning question to come down
Absolutely.
and ask her at the end.
Absolutely.
So thank you very much.
Oh, thank you. Thank you.